Hello, everybody. Happy Friday. Happy Friday, everybody. Wonderful day and third day of spring. Got to throw that out there. So today is our, I think, fourth session, our faculty development series session, pediatric specific. And we've gone through some different topics such as promotion. Last time we did, the 5-minute preceptor. We also did evidence-based education. And today we're going to do blended learning. So not quite all online learning and not quite all in-person learning, but a little bit of a mix. Sometimes you just need that balance. And so today we have Susan Kinder from Jefferson College of Health Sciences and David Finkler, whom you all know. And they, as you all know, these sessions, we're trying to do an expert in the area or in the field, a content expert, and then pair them with somebody within pediatrics to really help and provide relevant, the relevant relationships for you all. So thank you. Please join me in welcoming our two presenters today.
Thank you.
Thank you all. It's glad to be here and to share what we're doing. I teach mainly online, but I do teach in the classroom also. And Dr. David Halpin's with me today, and he's our IT specialist, and none of this would be possible without IT. So I tell him I need something, and then next day I've got an email with it there. So I do appreciate him. We neither have disclosures. I have nothing to disclose because I'm broke, and this was my nursing class. And now this is my nursing class that come in. If they're not in pajamas, they look like this. So there's been a big difference in them. We'll go over the objectives. We'll go over what is blended learning and how can you use it. There's a lot of research out there about pediatrics and teaching medical students in peds and using blended learning. We'll go over some examples. There's lots of tools out there, and some of them are free, so that's even better. We'll go over the current research, and we have completed 2 studies on blended learning, so we'll go over that and then see what questions you have. And I ran into something, and I thought, oh, my gosh, that felt like a person, but it was really hard. I thought I shouldn't have stopped at that pub, so I kept walking, and I ran into another one, and I thought, I need help. So I turned around and looked, and this is what it was. This was from the potato phantom, and you can see the dog and the people carrying their children and their food, and I thought that was really something to see that history right there, and it really brought back how much that country has gone through. I did kiss the learning stone. It was not very easy to do that, but I did. And the first question is, what happened when I got up? Did I throw up, dance the jig, pass out, or all of the above? Any answers? B? All right. Well, I was positive for postural hypotension. So blood pressure medicine will make it difficult getting up from a castle. But I had a really good time. The objectives today, we're going to look at current technology. We're going to look at tools and how we have implemented those. We're going to recognize and look at knowledge, skills, and attitudes and how we can implement those in learning modules.
So if you're like me and like a lot of my colleagues, when I told them that I was helping give this talk, the first question was, what is blended learning? And so looking into the research that's out there, I got a little bit of the history of it. Luckily, it's fairly short. So back in the late 1990s and then especially into the 2000s, as technology became more available and educators were looking for different tools to utilize in teaching their students, this idea came in place that you could blend sort of the traditional face-to-face educational models plus this distributed learning environment. And then, of course, there's all kinds of aids in the digital sphere that we can use as well. Here's a couple of quotes. So, blended learning is a method of teaching that integrates technology and digital media with traditional instructor-led classroom activities, giving students more flexibility to customize their learning experiences and combinations of different modes of delivery. And so seeing where blended learning is being used, it's sort of pervasive in the educational realm. And so both within the traditional educational environment, the military has found uses for it, and then relevant to us is in the higher ed classrooms, and so both in nursing and medical school education. And then in the literature, there are studies that sort of look at and evaluate the effectiveness of this type of model. And so most of these have found that it is equally effective to traditional methods, and that both the teachers and the students find it to be easy to use, flexible, and enjoyable. And you'll see a lot of these type of buzzwords in there is the idea that it can lend some flexibility to the current environments.
Okay, these are some theories. I used the constructivism learning theory. There was also an article in 2017 that discussed essential components of blended learning, and this is the one I used. Who I teach are already nurses going for a higher degree, so I look at what their knowledge is, their experience, and then I build upon that. So I can't go into a class and just post a PowerPoint because they're past that. They need to be interactive. They need to share what their experiences are, and then they need to use some critical thinking to predict what's going to happen. The first thing we did was a needs assessment. Our RN to BSN program at Jefferson was going downhill. There's so much competition out there with online programs, so we looked at why are our numbers going down. So we used the Dale survey. This is a survey of online teaching, and it evaluates not only the professors, but how quickly you respond. Do you use interactive? Are the students interactive with each other? And so we give that survey every spring to our seniors, and when we first gave the survey, we scored 25% satisfaction. So I think it was obvious that we were failing our students. Some of the areas we were low in access to faculty, so we set a time limit. Within 24 hours, you have to respond to your emails. I do an online office with Blackboard Collaborate, so they can just schedule a time and I'll see them on Collaborate. Instead, I've got students that are in, I had one in Alaska and Washington and different places, so they just can't come to campus, but we can communicate that way. Student involvement, we have students presenting on Collaborate their projects to each other. We have them grading each other on Collaborate and making comments. And you'll see the different technology that we have implemented. Was it easy? It was not, because we have professors who have taught for a long time by putting up a PowerPoint and expecting that to be interactive and the students to be interested in that. We implemented what are the best practices of online teaching and quality matters. We were all trained, and that is a very good credentialing for your classes. And then we purchased a system and trained the staff. We implemented Collaborate virtual classes, which when you say classes are online, or if you are presenting in the room and in the classroom and online at the same time, you don't have big interactions, but with Collaborate, I can see the students, I can look at it in an ear or listen to heart sounds, and I can see all the students at the same time in their homes with their family member or their patient, and I can call on them and watch them demonstrate that procedure. So it's more interactive. I can do polling, I can do different games with them, and they can ask me a question right then. I've had people say, well, why do you do this? You have to present the class 4 times to get a big class to be able to see each student. And I said, because I want it to be interactive, I want them to be able to ask that question then, not email me or forget. Virtual offices, I told you, is an easy way to do office hours. We'll go through a digital clinical experience, which is a digital patient, and we assess the patient then, and it evaluates you compared to the top schools in the U.S., and it grades your percentage. You can assess the patient, order tests. You have to say why the tests were ordered, order medications and why they were ordered. You'll order x-rays, and they'll come up, and you'll evaluate it. So it's the whole process, and then you're compared to other benchmarks. Voice threads, if you've done discussion boards, if you've had to grade them, you hate them because they're awful. The students hate discussion boards. So instead of doing a typed discussion board, I do a voice thread, which is you can see and hear each other and you can comment. It doesn't have to be synchronized. It can be asynchronous. And they really like the verbal voice threads. They still have to use their references and they still have to comment to each other's, but it's free and it's very good. E-books, most of your textbooks come with e-programs if you ask them, and they're free, and they are so good to prepare your students before they come to class. There's a lot of them. They have heart sounds, lung sounds, whatever, and they have case studies. So they have to do the e-book assignments before they click on to the Blackboard Collaborate. Voice grading, I broke my hand and called David and said, I've got exams to grade and stuff, and I can't type. What do I do? And Voice Threads is a free that you record and your evaluation of their assignment. And there's a lot of research that shows it takes much less time, and the students listen. How many listen? You can write all these comments and then say, do this and resubmit it, and they resubmit the same crap that they did the first time. So it's a good way to make sure that they do listen and that they respond back to you verbally too. Voice announcements, instead of typing an announcement that comes up in your course every week, put a short, all you do is hit the voice thread and you can hit the camera and you can record it. So it's more personal and they listen. Portfolios, I use portfolios from the first day they come into our program. They start putting their assignments into Blackboard Portfolio. And then the very last class, the capstone, they have to take the 6 program outcomes and put each assignment or each evidence that they met that outcome and discuss how they met it. And that can follow them throughout. So they'll have, when they graduate, they'll have this portfolio also. Okay, any questions on those before we look at some examples? Okay, and the first thing is, when you connect, is there anyone out there, and are they listening? And we have found so much better collaboration with our students. They answer us, they ask questions. We have access to connect with all of those capabilities. Jefferson. No, well, Jefferson has Blackboard Collaborate, but Zoom is free, and it does this.
Collaborate is built into Blackboard, so anybody using Blackboard can use it.
And everybody at Carilion has Blackboard access? Is that true?
If they don't, they have the ability to get access.
Yeah. And Collaborate we use for, what, 5 years or more? I've used it in courses, and it's been great.
Did I hear somebody coming through on that line?
They shouldn't be able to because it's muted.
Oh, okay.
Okay, so the classes, you can teach lectures, you can use iSpring where you're talking with your PowerPoint. We can get guest speakers. I had a nurse that's a lawyer from Southwest Virginia. She presented at one of our Collaborate sessions, and the students were live and could ask her questions. We had someone on complementary therapies. They had a dog, and so we've had them show complementary therapies, and they don't have to come to ours. They just click on. I send them a link, and they click on and they present, and everyone can see them and ask questions. It's a good tool to demonstrate and return demonstration. What we were doing before is we were demonstrating, and they were having to video themselves and send us a video of them performing heart sounds or checking ears or eyes or whatever. And then we'd have to watch it, then we'd have to give them feedback. Now I can see them right then and say, you're not holding the scope right, or I don't say it exactly that mean, but, move your hand to the right or left, and then we can see them right away with that, so they get immediate feedback. Polling and testing. Polling's great. You can see, are they getting this? Testing, they're vicious on this because I give prizes. And some of their patients are their kids or their parents or their spouse, and they get a point every time they type in the question. Have them type in the answer, because if you have them speak, it goes crazy with everybody speaking. And so whoever wins the most points, I mail them movie tickets, and they are vicious for those. The kids will say, Mom, she told you that answer a few minutes ago. You're not listening. So it's funny to see them, and I'll mail them the gift. So immediate feedback, we can do different types of games. I can record it, so, I teach nurses, and they work 12-hour shifts, so some of them cannot get off for this. You can hit record and save it. The best thing is breakout rooms. So you think you're online or you're teaching a class, and you want them to break into groups, okay? And you think you can't do that online. You can. It's very easy. Blackboard Collaborate will separate them into groups, or you can separate them into groups. Give them a topic and say, okay, go for 10, 15 minutes to your private room. When you come back, your group will present whatever. And I can click in and listen to the groups to see if they're giving me bad mouth or whatever too, but I can click in and hear them. But that is awesome, because if they've got an assignment that they need to do outside in groups, they can go into Blackboard and get into their group and not have to drive into Roanoke or wherever. So the collaborate rooms, the breakout rooms are very, very good, and we enjoy that. This is my PowerPoint that I have up, one of the pictures when I show of the ear. And then this is what we hope to go. David and I are looking at grants, and we want to purchase the equipment where the students, when they go with home health or when they go with an IP team, that if they're looking in the ear will come up on the computer screen, the tympanic membrane and everything, and we can give immediate feedback then. So instead of them just holding it right, I don't know if they're seeing anything, what they're seeing. But with these tools, we can see exactly what they're seeing. So, and that's going to be so good for telemedicine and home health and all your others. We want to do it interdisciplinary. So if let's say I've got a stroke patient, and so we have to go through legal, and we have to get permission of the patient, and they would use this Blackboard Collaborate, and we would see them assess the patient. We would have a physical therapy student there, an occupational therapy student there, and we would have them, and all the professors would be watching from their office. So we could do it interprofessional. So that's our next goal, is to do this interprofessionally. And this is the otoscope, and they range from some of them are $198 to $400. But if we can get some grants and get them, and I'm sure they'll go down. I talked to a doctor in Alaska that uses telemed, and they have to do it because their patients are so far away, and they have problems with transmission sometimes due to the weather. But she said overall it's been very successful. Now this is an ear that is transmitted. And there's another ear. This is my mom. She was 93 Monday, and she's my patient. And this is me teaching on Blackboard. What I want you to see is look at the bottom. Is that what your students look like, or are they on their phones, okay, or on their laptops? They are paying attention. First, they want to win the prize. And second, I call on them. They don't know when they're going to be called on. I just call on them, and they have to answer, okay? So this is me showing my mom. She's 93, and she told me on her birthday, she said, I'm not sure if I'm going to make it next semester, but she said, John down the hall, he is 89, and he's got a few more good years in him. So she loves to be part of it. Now, this is a link that you can link to your phone, and you can, after you put drops in the eyes, you can transmit the eye. So if you're in ER and you've got a patient that has eye trauma, and due to weather or whatever, you can't get the doctor in, you could transmit that. Isn't that awesome? And there is the eye, and then if I do it in a class, you can hook it to your computer on the right. Okay, heart sounds and lung sounds. This little one on the right, the little blue one, that is only like $190. And it will transmit the heart sound. So if you have a kid in heart failure or an adult in heart failure, you could use this with home health to listen to their heart sounds and lung sounds. So those are awesome. Some of them just click on your stethoscope, and then some of them are individual ones, but these were more expensive. Okay, we want to show you, let's see, David, where did you put this? Control Alt.
Alt tab. Alt tab.
Sorry, I need to put my glasses on. Okay. All right. We want to show you Shadow Health. Okay, now Shadow Health is required before they come into the virtual class. So this is patients that are digital patients. You ask them questions and they respond back. It compares your documentation to benchmark. It gives you quizzes. It has heart sounds, lung sounds, all the different organs. There is a family. The first family is the mother and dad get married. Then they have a kid, so it's a baby, and the baby goes through developmental problems. Then becomes a teenager and gets addicted to drugs. Then Granny has to move in because she has dementia. So it takes you throughout the process so you can see.
Labs let you listen to normal and abnormal sounds to train your ear before you interact with these patients. After each patient interaction, you can practice interprofessional communication, answer questions about health differences across the lifespan, and reflect on your clinical approach. Gather information critically and talk to your patient strategically will only improve with each conversation. Over time, we know you'll make more clinical connections and provide better quality of care to your real-world patients. I suggest you jump right in and start the orientation assignment, which explains how to navigate the DCE and interact with our patients.
Okay, so that program costs students $90 a semester, a $90 one-time fee, and it is they will go through ordering the test, assessing, ordering the test, doing the interview, and then ordering the meds and teaching. It goes also through patient teaching. So it is very good because it takes them through a family and a lifespan.
How long approximately does it take to get through the whole lifespan?
We do one a semester. So with geriatrics, I'll do the granny. With peds, we'll do the kid.
One aspect of it.
Yeah, we do one aspect at a time, but they only pay one time for it.
And then how much is it for a faculty member to?
Nothing. It's nothing for the faculty. Yeah. So they really like that, and the students will comment that they like it because it compares them to a national average and benchmark, and we have been averaging over 94%, which is good for only using this for 2 years. So the pre-work before we do a virtual class is that you do your e-book assignments, that you go to Collaborate and you do that, and then we will do the class. VoiceThread, I'll just show you. Okay, sure. Sorry, I don't. Okay, we will. Where is it? Here, I want my bottom. Sorry, we put them all down here. Okay, VoiceThread. Here is one that I did on veteran care to implement that into our programs. So I did a little pre-thing about a soldier, and so I have him recorded talking about it, and then he will, then each student has to. Now, is it hard to use it? Not at all. You click here and start recording. That's it. And then I get a link, and I post that link in my course, and they click on the link, and that's it. And this is free. So Vocaroo is really, really a good one. I can do my grading in this, too, and just post a link, and they click on the link, and will hear me grading. Okay?
So Vocaroo is like a full system, like a learning management system?
No, just voice. Vocaroo is just voice. VoiceThreads is picture and voice, or you can type. It gives you the 3 options, but Vocaroo is just voice.
and then you would grade their interaction.
Right. Now, I think David has presented here about screencast. That's another option. So there's a lot of different options out there that you can look at. So look at those links. All three of those are free. So voice grading, use Vocaroo. Discussion boards, voice threads, okay? And all of those are real easy to use for the student and for us. I'd much rather grade a video of a student talking than written stuff. Okay, here's an example of ebooks. So look at what your ebooks have. I'm sure you all use concept maps for diagnosis. There's free programs out there that they can build a concept map. Instead of doing nursing care plans, we do concept maps. But I took it one step further, and I require that they also do an interprofessional care map. So for that patient, what other professionals are needed. And this is a great documentation tool where you can post it in your patient's chart, and then each discipline would go and see what they're responsible for, click on it, and document. And then that's one view you go to see how they're doing in physical therapy, how they're doing. And this is used not in a hospital right now, but I'm trying it with home health. So it is just a good alternative.
You all may not recognize the term concept map, but it's probably something that you're doing, but by just making connections throughout the patient care experience. So how all of these things are interrelated, and then this appears to be a way that you can do this online, and they can click on and focus on the related or their applicable area of interest or involvement, right?
And so I went looking for examples of blended learning being used currently in the pediatric realm. There's not a ton out there that I could find. A lot of it was also from overseas, but I highlighted a few here just to show you again that places are using this and more places are looking into it. So here is one study. This is looking at essentially your third-year medical student going through a pediatric clinical rotation. It's from a few years ago, and they had about 200 students and doing their clerkship. So they did the standard learning, so a sort of a straightforward clerkship as we think of, and then having a separate group where they did a blended learning. And so they had online activities similar to what Susan was talking about, so video presentations, virtual patients, online training modules, and then they compared those two groups, which we'll get to. So again, this is essentially separating out the groups. It's hard to readily assess, I guess, how the outcomes were for this. It can't be a placebo-controlled trial, so to speak. So what they used was essentially the end of clerkship exam scores, and then also eliciting surveys from the students themselves. And so this shows sort of the breakdown. So about a third of the students did the blended learning, and then they sort of studied those, and Overall, the comments were very positive. This is one quote. So one of the survey questions, that the integration of both the e-learning plus that face-to-face helped me learn, and the majority, 83% of those students, agreed with that statement. So essentially the results showed that there was no difference between their exam test scores at the end. They did find that in the blended or e-learning group that they had a higher percentage of honors in that group compared to the control. But looking at the numbers, to me, it more reflected on the fact that almost half of their class was getting honors, which I'm not sure what honors means anymore. But anyways, essentially it showed that there's no difference. And a lot of the studies are looking at that because it's hard to show a superiority, so they're essentially looking, in a way, sort of at a non-inferiority, comparing these new models versus traditional.
Did it say what the criteria for honors were for that basal test score?
They did not, but it often includes if you get a certain percentage or higher on the test score, plus evaluator comments and that type of thing. All right, and so this second study was a tool, and there was not a control in this, but essentially trying to teach the medical students a way to use evidence-based medicine. And so they created this electronic e-assignment that these students would go through, and they would work towards a project of that would, sort of a research project that would teach them along the way on how to accurately assess and find evidence-based medicine. And so they showed that essentially the same types of outcomes, like looking at surveys, that the majority found it enjoyable, they found it effective, they felt like they learned from it. And so this group essentially used that to conclude that model was something that they were going to use further down the road for their students in addition to the more traditional learning for that. And then these next two studies, so this first one was one of the few that I could find from the U.S. So this is a short publication that came out of Children's Nationwide up in Columbus with their pediatric residents. So essentially they understood the barriers that a lot of us do, in that between duty hours restrictions, the change to more shift work, that there have been less opportunities perhaps for residents to get some of that hands-on encounter with patients. And so specifically, they were looking at pediatric patients with neurodisabilities. So, for example, a patient with cerebral palsy, and how to teach residents quality physical examination skills. And so they, again, did not have a control with this, but what they did was they created sort of an e-learning system in which they had one of their developmental pediatricians create a 15-minute video of his physical exam of a patient with a neurodisability in clinic. So prior to their behavioral developmental rotations, all the residents were required to watch this video, and then during the rotation, they all had a standardized sort of exam, so to speak, in the sense that practitioner would observe them perform the physical exam on a patient in clinic with a neurodisability and then rate them on how they did. They showed that the majority of students found that the video was helpful. They felt like it prepared them. And then when they looked at the exam scores, they had fairly good numbers in terms of the percentage of residents that scored highly on that exam. But again, the lack of control data from prior to implementing this video-based approach, you couldn't compare exactly to what it was before. And then this last one, again from overseas, this was out of Germany, I believe. So here they were looking at essentially the pediatric BLS teaching. And so this study broke down a little bit differently. So it was sort of trying to compare different modalities of a blended learning environment. And so they had about 100 medical students, and they separated them into three groups. So essentially, the first group would watch videos of, similar to what I think a lot of us are probably familiar with in terms of BLS or advanced life support training, of a video of somebody going through sort of the steps of the procedures and the knowledge. The second group had a virtual patient that was interactive, and so similar to the type of website that we saw before, where you have a virtual patient, you can interact with them, you can do a physical exam, you can do maneuvers. So obviously this was more geared towards BLS. So, but they had all of the different options that you could do, and so it's that idea of an interactive environment. And then the last had virtual patients, but they weren't interactive. So essentially it was static images, it was text, and so they didn't have that ability to interact with them. The outcome that they looked at was essentially a competency level based on those three groups, and the one that scored the highest was the virtual patient interactive group, more so than the video. The static images and text scored much lower, so sort of not surprising to me at least, but that was not as effective of a approach.
Okay, what are the outcomes of our study in our NWSN program? We received, as I said, 25% the first year. 4 years later, we're over 95%. We have doubled our admissions, and our benchmarks were scoring over 94% compared to the national average. So we feel that we have accomplished it. It was a difficult journey, especially for faculty who didn't like to be interactive teaching, but it was a successful journey. We are implementing another research study this semester, and we're looking at geriatric attitudes. Do they change in online courses? We're using interactive Gero instead of just PowerPoint. We're having patients or family members that are geriatrics tell their stories, and we're interviewing them, and we're using a lot of interactive there.
So I guess, where do we go from here? So trying to think about, for us as pediatric faculty, so I think one of the things is just understanding sort of what blended learning is, that it's out there, and in fact, we are, to some extent, already utilizing it in some spheres. So hopefully everyone's familiar with the Blackboard and MedHub, but so we have articles that we post on there. It sounds like there's a lot of potential other, like with the Blackboard Collaborate, other things that we could perhaps be using in those. The nighttime curriculum for pediatric residents, and so this is, again, coming from that idea that, especially with shift work, and so if you have a resident on a night float rotation, they may not and probably are not getting some of that direct hands-on feedback and evaluation from a faculty. If the faculty is at home and the resident's there in the hospital, they're not getting some of that learning that may be occurring during the daytime when everyone is there. And so this was a curriculum that was developed out of Stanford to essentially provide them with some case-based learning opportunities. And the idea is again, if you can, like if you have a second year and an intern on nights together, they can go through a case together with the more senior resident being able to provide some of that education to the intern, but again, a lot of it coming from the content itself. So not exactly quite blended, so to speak, but I wanted to mention it here just because it involves the use of technology to augment sort of traditional teaching methods. And so some of the things that I've been involved in is using the Simeon Center to provide education for residents, and then also the mock codes. And so I just wanted to show you a quick example that I have here on my iPad. So for any learning environment, especially in simulation, the more realistic you can make it, the better. And so, if you have limited resources, so for when I'm up on the floor with the residents and the students, I wanted the ability to do a mock code without having a what we call a high fidelity simulation model that can blink and respond and have pulses and all that. So essentially just being able to use a standard mannequin, or in some instances just an infant baby doll. This is an app that's available that you can put on an iPad. It will sync to my phone. And I'm not sure if I'm at liberty to endorse that or not, but it sounds eerily familiar. All right, so of course it's not going to work now.
That's part of it, technology challenges.
You can see how easy blended learning is. So I can show you essentially the idea is it'll sync with Bluetooth to my phone, and I can control the patient vitals. And so by just having a simple mannequin there, I can control from my phone what's going on with the patient. I can change things real time, and what if they ask for, as the residents are asking, they can cycle the blood pressure cuff on the screen. You can essentially run through here and have any scenario that you want with that patient.
Is that a free app?
I paid about $20 for it, but the iPad was a gift from the department. But again, just the idea that, and that's just one example. There are so many apps and websites and different venues of technology that I think could be used to create a more realistic experience for our residents, rather than like if it's a clinical experience that they may not get exposure to or have repeat exposure to. You can find ways to create some realism. And so essentially that's my last point there is just think about your own teaching, think about ways that you could perhaps implement some of these things that we've talked about, or look out there because, there's a lot more than I think that I or even Susan know about.
Okay, any questions?
Yeah, just
Yeah, this is Mike Hart. We always focus on, it seems like whenever, because this is to me a no-brainer, this is just a win-win, great opportunity, all the bells and whistles. But it seems like whenever you do surveys of students, oftentimes you'll get a 15 to 20% of, not negative, but you see the numbers, 75% or 85%, very positive about the experience. We study those, we try to improve those numbers, but has anybody really in a scientific fashion looked at those, you want to call them non-responders, non-enthused, I don't know what you call them, to find out is there something about their learning process? Are they not a type of a learner that it fits, and because that, if you are not amenable to this case-based study or these other, then it may be a waste of money on both ends of the spectrum. Does that make sense?
Right. Yeah, there are learning styles. We do a learning style assessment the first day of class to see what type they are, and we discuss this is what this program, how we teach in this program. What we find is that we have older students coming back for higher nursing degrees, and they aren't as happy with the technology. But once
Could you elaborate about why?
Okay, they're just not used to the technology, they said. They haven't used the computers that much, but once they learn it, they're our number one. They love it. But we have that no matter what. But it is required that everyone does the survey, and so far we haven't had any overwhelmingly negative. Now, we've hired new faculty, and some of them aren't as much into technology, and their courses, we just looked at the course evals for both. The ones not using technology are getting much lower scores than the ones using technology.
I think that's always going to be the issue, no matter what course you're looking at or, how you're conveying the information, that there will be folks who don't love it. So I think that's one of the joys of blended learning. It's not all one thing or another. You're getting a little bit of a mix of both. And I think the learners are evolving, and our younger learners are more adept than even a lot of our faculty are at using these technologies and offer suggestions for the technologies that are easy for them. The problem is that the technologies are evolving so much. So once you perfect one thing, then there's something else really cool that's out there and even better. So it's sort of having to keep up with those. But some of these things like that Susan presented, those are very foundational and basic, and that you can use with any group, I think. And I think a lot of the times that we see these studies, and so the results are equivalent. It's not better, not worse than, solely in person or solely online. But then you think of the convenience factor, and it does take a lot of work sometimes to put in and redesign your curriculum or your sessions to adapt to a blended learning. But then I'm also hearing, on the other hand, I can't even fit all my learners in a patient room. I can't even get to all of my learners at different areas. So you have to weigh the cost and the benefit of doing so. But I think that the benefit in a lot of situations outweighs the cost of, the initial
you're making rounds and you have a patient that has a disease that's not common. You could do this in the room. You can also do it on your phones. So you can do it in the room, and your other students that might be in the lab or in a classroom can watch you live and can ask questions. Of course, you have to get permission of the patient and everything, but there's so many places we can go with this. I'm worried about going to Radford because if David doesn't go with us, I think I'll take early retirement because if I have a student that's having problems, they call David and he gets on the computer with them and he teaches them, and that's the benefit of having a great IT department, that these that are challenged technology, they call David and he gets them up to par.
And David's not just at Jefferson. David is a Carilion employee, so is accessible to all of us to help us through this process.
You want to unmute the phones here in case anyone has a question? All right, if you're on the line and you do not have a question or want to make a comment, just please put your phone on mute now.
The conference is now in talk mode.
Does anyone on the line have a question or want to make a comment? Scared them all off. Nope. Guess you're good to go.
All right. Thank you.
Thank you all very much.
Thank you all.